very much. It's really delightful to be here. You're right. In fact, to be precise, can you hear me okay? Sorry, I'll just move that a bit closer. Is that a bit better? Okay. So to be precise, I've been in the post exactly 1 month as of today. In fact, a colleague brought me a little cake in yesterday to celebrate 21 working days. So it's nice to have been preceded by a politician, because you know that thing that politicians often have, the brief constantly change, and they're sort of arriving at an event needing to be masters or indeed mistresses of a particular brief. And so I feel a little bit like that being amongst such honoured guests. You'll have a huge amount more knowledge, frankly, than I will. So I'm going to do two things. Firstly, I'm going to convey some information to you about something that we've been working on. So you'll forgive me if some of this is slightly unfamiliar to me, but I'm also going to take a professional risk and probably something relatively unusual. And a couple of slides there from my interview for the job. So at least I got the job, so they couldn't have been that bad. But anyway, thank you. It's really nice to be here. So I'm covering three things really: what public attitudes to mental health, what does palliative esteem mean, and what are the best interventions that make the biggest difference. So firstly, we talk about palliative esteem. That's become a sort of phrase du jour, hasn't it? But what do we mean by palliative esteem? Well, at Rethink Mental Illness, we define that as equally valuing our physical and our mental health. And although I'm going to focus on the mental health aspect, clearly there are a wide range of socio-economic factors which impinge on people's mental health. Issues such as housing, social exclusion, employment, of course, and I know that's going to be picked up a bit later on. And it goes without saying that stigma and discrimination are two very significant barriers to palliative esteem. But there is a huge gap out there. The rhetoric has probably never been better. We hear mental health talked about, I guess, more than we ever have done for many, many years. But what is the reality on the ground? There is a very big gap. We know that in terms of premature mortality, that people who are living with severe mental illness are dying up to around 20 years early, and that's because of various comorbidities. There is a serious problem, I think, that we have this split between the body and mind, and people, particularly as patients, tend to be seen either as having mental health difficulties or physical health difficulties, and actually the two, as you probably all very well know, are so closely interlinked. And I think in our case we know, for example, that there are 46% of all tobacco that is smoked by people with mental health difficulties, and that's an extraordinary number in terms of a public health change. There are roughly 30,000 avoidable deaths, by which we mean the people didn't need to die because of that, and those are usually arising from either the physical effects of mental health or vice versa. And actually, many of our supporters tell us that they go in to see their health professional, and actually either their mental health condition becomes the sole focus and the consequent physical conditions are not necessarily addressed, or again, sometimes the other way around. And that the danger is that is overshadowing the effect of somebody's mental health problem. Now, the government obviously has a huge commitment, a very clear commitment, to reduce the number of avoidable deaths. There's still, we, and I'm sure many of you, are still have a really strong ambition to introduce a quantified national reduction in premature mortality. So the reality is, I think, is pretty difficult. So what are some of those barriers to making that change? Well, there are a number. I'm not going to go into them in huge amount of depth because you'll be familiar with them. There's the legal issue, so the fact that the mental health law has developed over the years, and actually you can be restrained and you can have treatment imposed upon you because of your mental health condition. There are serious problems around funding. We know, of course, that mental health services were cut disproportionately last year by 20% more than physical health, and that is a very serious problem, I think. But also, actually, there's no kind of recognised tariff, and that makes it very difficult to argue for investment. And of course, it goes without saying that one of the biggest issues is stigma, and that's something I'm going to concentrate on. So how do we match the gap between, if you like, reality and rhetoric? Well, I'm going to pick up, just very quickly, if I can, an example from my previous career. I'll do a little bit of public polling here. If I said CFS, I'm going to just get a show of hands recognition of what that is. People heard of that? ME? Anybody can think of another name that used to be called? No? Nobody remember Yuppie Flu? Yuppie Flu, that's what it was known, well, actually 10, 15 years ago, and it was widely called that. Now, we don't know exactly what CFS or ME is exactly. We don't know what the cause of it is. We don't know what there certainly isn't a diagnostic test, and there is no sort of single treatment. And it may be a cluster of different things, but it is a very serious illness. And having worked for an ME organisation a number of years ago, I met lots of people whose lives were wrecked, who were not malingerers, who were not yuppies seeking a bit of a break. They had very serious illnesses. And actually what you see, we'll just skip through that, is a combination of factors, don't you? The media will perhaps report on a sensational story. I used to be a journalist, and one of the old maxims in the newsroom is news is extraordinary things happening to ordinary people, or ordinary things happening to extraordinary people. So, you know, for ME, substitute a subject that we, of course, at Rethink Mental Illness focus on, which is schizophrenia, and it's exactly the same pattern. You get stories about ME, or you would get stories about schizophrenia. They dominate the public consciousness. That then forms in the public's mind a view of what the illness is. And inevitably policymakers either do or have to respond to some of that public consciousness. And that bleeds into the way I think health professionals operate. I have many stories, I have to say, of people with ME who would go in to see their doctor, and they would be reporting the effects of physical symptoms, and the doctor really just wouldn't take that very seriously. And because professionals don't take it terribly seriously, there wasn't a research programme into ME, CFS or yuppie flu. And patients actually became incredibly isolated. You can see the same thing happening there with schizophrenia. And actually, what is it that changed it? Well, it was a combination of factors, and I'm going to pick up, and this is where I go through my presentation. Firstly, it was the medical profession taking it more seriously. Well, I say firstly, just to be clear, I think there is no first here. This is a circle, and each part affects the other. But certainly the medical professional, in particular the chief medical officer, issuing a report, I think back in 2001, saying that the medical professional ought to take this illness more seriously. Because it wasn't understood, wasn't a reason to dismiss it. That old thing that evidence of absence is not absence of evidence. And I think as a patient organisation, we were very tough on journalists who would use phrases like yuppie flu. And, you know, I'd phone them up at 6 o'clock at night in my kind of Scottish accent and threaten to come around and see them or their editors if they used that again. But we were very tough on that because you had to be, because that sets the climate, doesn't it? And actually also having a better relationship with health professionals. It's a fact to say that an isolated group can become very antagonistic, and there was quite a bad relationship, I think, between some of the patient groups in ME and some health professionals. So actually trying to heal some of that climate. And I think I'm going to go as far, well, I think the audience participation there demonstrates that yuppie flu is not really a phrase that's used, thankfully, anymore. So people don't feel stigmatised. People don't feel like they can't go out because they'll be laughed at. So that's great. And of course it helped. There were 2 or 3 very powerful and very sad cases to do with ME, some of which you may remember. So I'm going to move on now to talk about a big public intervention that Rethink Mental Illness have done in partnership with Mind, our partners. As you know, it's lottery funded, along with the Department of Health and Comic Relief, and that's the time to change, which is all about ending mental health discrimination. So I picked up on this before, but some further stats for you. So 88% from the Institute of Psychiatry Viewpoint Survey, 88% of people using mental health services experience discrimination. That's an incredible figure, 9 out of 10 people. And 60% of people said that stigma was actually more damaging than the symptoms of their mental health problems. So actually the kind of process of being stigmatised felt for them worse. And a quarter of people who'd experienced stigma had said it made them want to give up on life. And I don't know about any of you, but I find that a pretty appalling set of figures. So there's a very serious impact of stigma on people's actual outcomes. And they affect all areas of life. So people talked about those main aspects of their life that were affected by that. And that's, of course, amongst friendships. In fact, as I came into this job, I spoke to an old friend of my brother's who talked about his experience of schizophrenia, and he told me that actually the only people that really understood him were his family. Friends didn't really get it, and I think that's really difficult for people because you need that network. In the workplace, we know that the mental health illness has a huge impact on the number of lost days. In fact, it is the biggest cause of lost days. I'm sure that's something Andy will pick up in a moment. In family life, in relationships, and, as I've sort of mentioned here, in their interaction with health services. So the outcomes we were trying to do in the most recent phase of the Time to Change programme were to reduce discrimination by 5%. That may not sound like very much, but if you think about the number of interactions that people have and the number of areas of their life in which people experience discrimination, we sort of feel it's a substantial figure. To improve the confidence and the ability of people with mental health problems to actually tackle discrimination, to fight back, if you like, and to improve the social capital, which is a sort of jargonistic way of saying how are people able to interact in those different parts of their life. So there's many different strands to the campaign, and I hope that most of you are familiar with one aspect of it or another. The first is a national engagement dimension. So you'll see that we've taken out tube adverts with a number of different proactive media campaigns, storylines on soaps, and actually you may have seen recently a recent piece of research that was produced which demonstrated for the first time that it's a small majority, but at least it's a majority of soaps that covered mental health issues did so in a positive light. So I think it was 52%, 48%, and that's really good progress from where we were a number of years ago. It's actually soaps do, help create a sense in the public's mind. Through community engagement, local events, grant-funded, stakeholder partnerships, this is, getting out to people in their communities, in their areas. And actually really important for the Time to Change programme is individual action and empowerment. So it's not health professionals or charities doing stuff on behalf of people with mental health illness, it's people doing those things themselves. So we have a really strong champions network, which I'll talk about in a second. So the social marketing campaign the last phase launched in January 2014. It's the little things, so those small things that make a difference, and that was around giving public tips for supportive behaviour that we want them to adopt. I mean, it's interesting if you look back, I wouldn't claim that it was as well known as some other public health stats, but I think the 1 in 4 statistic has really become framed in the public consciousness, the notion that 1 in 4 of us will have a mental health problem at some point over the course of the year. And that's become really well framed, and I think that's terrific. But I think you need to do that through constantly getting through to people in their touch points where they are. So there's been high-profile banner campaigns, high public credibility, I think, and that people feel confident campaigning alongside their own communities. We run a series of events, so village events, so this is pop-up events in schools, and if you've been to one of them, I hope you'll have enjoyed it, and I'd recommend that you do try and get along if you can. They're terrific events. They're sort of run like a sort of, how would you put it, sort of a festival almost. So the children all years go through, and they kind of find out about mental health, and they're able to talk about it and experience that. So those work really well, but we do those in schools, and we do them in cinemas and other places. We're doing quite a lot of work with particular BME communities, and I'll come on to that in a second, including Stereo Hype, which is an interesting name, and various different grant-funded work. Social leadership. So this is growing the movement of people who have mental health problems, who are able to kind of actively get out and promote the need to talk about that. So our Champions Network has over 3,000 people, and they're all trained to go out and connect with people right across the community, whether they're affected by mental health directly or whether they're carers or professionals. So we have 8 regional coordinators and 6 equalities coordinators, and they're at every level of the Time to Change campaign, right across the government, so helping make the decisions about what the campaign looks like. I was along at a delivery event yesterday, and people are there making the decisions, but also about the management and the implementation of that. As I said, a lot of work with BME communities, particularly African and Caribbean communities, where there's a high prevalence of mental health, but equally a lot of people don't feel as confident about speaking out about their health profession, speaking out about their mental illness. So we have dedicated coordinator posts who support people, champions who have lived experience, and a number of different social contact events in places like Leicester and so on. Our 300 Voices pilot project, now I've spoken to the people who lead that, and they say although we're having some difficulty in recruiting the number 300, those men who have been recruited, it's made a massive difference to give them the confidence to work within their communities, to share their stories, to work with the police, so for example, to make sure that people are not taken in through the criminal justice system inappropriately, and the wider community engagement that they feel confident to embark on to help tackle stigma. So that's making a really big difference in those communities. So in terms of the impact of time to change, I've deleted the sort of 25 randomised controlled trials because I thought they were a little bit technical. Just concentrated on a few things. So since time to change has started in 2007, and there's been a 6.4% improvement in attitudes. Now again, that may not sound like an awful lot, but if you think about the kind of huge number of interactions that people will have, that's making a substantial difference to people's outcomes. And since phase 2 started in 2011, there's been a 4% improvement in attitudes. We also do talk about behaviour, so the way that the programme is evaluated is not just about attitudes, because we can all have attitude, in fact we can all say we have attitude change, but actually people's behaviours are measured as well, and that makes a big difference. And in the last year we've had 2.8% improvement, so that's the biggest annual shift we've ever seen. So just to say a really quick bit about this changes in experience. So that's, you know, less people feeling shunned, having better contact with their friends and family, and that relationships with mental health staff are getting better. People feeling more confident about dating. That their physical health is getting better as well. So you can see if you compare those two graphs, actually there's a gradual improvement. There's still an awful lot of work to do in some areas. So there's still a huge amount of work to do, I think, and helping people find and keep a job, and helping employers work with people who have mental illness, particularly severe mental illness, to support them. And again, we know that there's a huge number of employers, both in the public sector and the private sector, who've signed up to the Time to Change pledge to then go and make the changes to their employment practices. But we've got an awful lot more that we can do. So I suppose in slightly new Labour speak, there's a lot done, but I think that we've got a long way to go. Only 28% of people in 2013 agreed that women who were once patients in a mental hospital can be trusted as babysitters. So the majority of people think that if you're a woman, you've had a mental health problem severe enough to be in hospital, you shouldn't be watching your kids. Nearly 1 in 10 adults think that people with mental health problems shouldn't have the same rights to a job as anyone else. Okay, you might say 1 in 10 is not much, but how many of those people might be on employment panels? And nearly half of people said they would feel uncomfortable talking to an employer about their mental health problem. Just imagine that was a physical health problem. Imagine diabetes and saying half of people with diabetes felt they couldn't talk to an employer. The employer ought to feel ashamed of themselves if that were the case. So there's an awful lot done, Time to Change and other programmes, and I'm sure that all of the work that you're all doing out there is making a difference. But I think we still have an awful long way to go. Thank you.
Okay.